Welcome to the review of diseases of the nervous system. We're going to be starting by discussing neurological diagnosis and localization. When diagnosing in neurology, it's important to start with localization. This helps you determine where in the nervous system a potential problem is going on that could explain the patient's signs and symptoms. We'll start by considering the different areas of the central nervous system and peripheral nervous system that you should consider when attempting to localize a lesion. Here's a list of different potential localizations that can occur with the central nervous system. There's the cerebrum, which consists of the cortex and its underlying white matter. The basal ganglia and thalamus are deeper structures beneath the cerebrum. The cerebellum and brainstem are more caudal in the posterior fossa. And lastly, the spinal cord is part of the CNS. The peripheral nervous system is all of the nervous system outside of the brain and spinal cord. There are a number of different potential areas where problems can localize in the peripheral nervous system as well. Going down the list, starting from actually within the spinal cord, we have the problems involving the anterior horn cells localized on the ventral portion of the spinal cord. You can also have problems in the dorsal ganglion, which is where the cell bodies for sensory neurons are located in the peripheral nervous system. Problems can also arise from the spinal roots, areas where nerves are leaving the spinal cord, at plexi, such as the brachial plexus and the lumbosacral plexus, at specific peripheral nerves that you studied during anatomy in first year, at the neuromuscular junction, where axons release acetylcholine onto receptors on the muscle, and within the muscle itself. Injuries to upper motor neurons produce hyperreflexia as there's loss of regulation on the lower motor neurons distal to the upper motor neuron that's injured. In contrast, injury to lower motor neurons produces hyperreflexia. Injuries to upper motor neurons also produce spasticity in the affected limb, which is increased tone that is velocity dependent. While initially trying to move the limb might result in increased tone, eventually with increased velocity of movement, you can reduce the tone and suddenly it becomes loose, known as a clasp knife phenomenon. Lower motor neuron injuries produce atrophy as the muscles innervated by the lower motor neuron no longer receive continuous signals and thus wither away. They also display fasciculations as a result of inadequate signal from the lower motor neuron. An important clinical examination maneuver to test for upper motor neuron lesions affecting the foot is to test for Babinski's sign. In order to check for Babinski's sign, the foot is stroked with a sharp object towards the toes. In a normal adult, the toes will fan downward. However, in individuals with upper motor neuron lesions to the feet, the toes will fan upward. This is also seen in infants that are less than 6 months of age. A way they like to remember this is that it's a baby pointing towards the sky with their toes. Here's a table displaying the different localizations of peripheral nervous system problems. I know it's a lot of information to take in, but we're going to be coming back to it as we review other lectures. For now, let's just review some features of these different localizations. Sensory ganglionopathies only affect sensory modalities and occur bilaterally. They also result in loss of proprioception and loss of reflexes. Lower motor neuron diseases only affect motor function and occur either diffusely or in a single limb. A key feature is the involvement of paraspinal muscles. Radiculopathies involve both motor and sensory modalities and generally occur unilaterally. They frequently result in pain and sensory loss in a specific dermatome and a weakness in a specific myotome. Plexopathies involve both motor and sensory loss. They occur unilaterally and can result in a Horner syndrome when the C8T1 roots are affected and incontinence when the lumbosacral plexus is affected. Mononeuropathies involve both motor or sensory loss. Mononeuropathies affect the distribution of a specific nerve. Polyneuropathies can involve a lot of different modalities and can be further classified into axonal neuropathies and demyelinating neuropathies. Neuromuscular junction diseases occur bilaterally, usually symmetric, with normal reflexes. Myopathies results in motor loss, and reflexes are also usually normal. Moving on to central nervous system diseases. Lesions in the spinal cord produce recognizable syndromes of weakness and sensory loss. Because the corticospinal tract's dorsal column medial lemniscus pathway and spinothalamic pathway all travel through the spinal cord, a transection produces weakness and sensory loss at the level of the lesion and all spinal levels below. We will discuss patterns of more complex spinal cord lesions later, such as hemisection of the spinal cord, but for now it's worth recognizing that below the level of the lesion, there is an upper motor neuron pattern of weakness, but in myotomes directly at the level of the lesion, there is a lower motor neuron pattern because of damage to the alpha motor neurons in the ventral horn gray matter. Urinary incontinence from overflow or spasticity also occurs with spinal cord lesions because the sympathetics and parasympathetics that innervate the bladder are also interrupted. The brainstem is a densely packed structure that carries all sensory, motor, and cerebellar tracts and contains nuclei that control vital functions like breathing, maintenance of consciousness, and modulation of heart rate. While there are many different brainstem lesion syndromes, one tip-off that a lesion can be localized at the brainstem is finding cross patterns of weakness and sensory loss. For example, a patient's right face and left arm and leg might both be weak. This occurs because in general, cranial nerve nuclei are located ipsilateral to the structures they innervate, but the corticospinal tract and medial lemniscus pathway eventually cross over to the contralateral side in the lower part of the brainstem. So for example, a large lesion in the right pons will interrupt the right facial nucleus and cause weakness in the right face, as well as the right corticospinal tract before it crosses over and innervates the left side of the body. The cerebellum is involved in motor coordination and precision, so lesions here produce a type of vein coordination known as ataxia. Lateral lesions cause ipsilateral limb ataxia, and midline lesions produce truncal ataxia. There may also be involuntary rapid oscillations of the eyes, called nystagmus. Cerebellar lesions may produce a tremor during actions such as reaching or attempting to grab an object. The left and right thalami are egg-shaped structures perched on top of the midbrain. The thalamus is an important structure for coordinating activity across regions of the brain and relaying important information such as complex cognitive, sensory, and motor functions. The thalamus is divided into many different subnuclei, so lesions in the thalamus can produce many different syndromes. It's worth knowing particular presentations of thalamic lesions, such as complete hemisensory loss that affects all sensory modalities, or thalamic pain syndrome that produces allodynia over an entire half of the body. The posterior limb of the internal capsule runs between the thalamus and the basal ganglia. The posterior limb carries fibers in the corticospinal tract. Because of this, lesions to the thalamus may also impinge on the corticospinal tract and produce hemiparesis. The basal ganglia are deep structures located anteriorly and laterally to the thalami. Damage to the basal ganglia produces movement abnormalities that are apparent at rest. There can be limb rigidity due to contraction of both flexor and extensor muscles. Chorea is classic for Huntington's disease and appears as abrupt, dance-like, spontaneous movements of the extremities. Dystonia is sustained abnormal muscle contraction. Tremor from basal ganglia dysfunction is most apparent when a patient is not otherwise moving their arms and hands. Cerebral lesions can produce very many different distinct clinical syndromes. When cerebral cortex lesions occur, sensory deficits may occur on the contralateral side of the body. However, sensory deficits are generally not as broad as in thalamic lesions and do not affect as many somatosensory modalities. For example, a patient might only have deficits in position sense, or might have deficits in higher level integration of somatosensory information, such as an ability to identify objects by touch. When lesions affect the motor cortex, an upper motor neuron pattern of weakness occurs. If the dominant cortex is lesioned, a patient can develop aphasia. If the non-dominant cortex is affected, a patient may develop neglect, and you can also have seizures that result from irritating cortical structures. Lastly, you should consider localization to the meninges which surround the brain. Meningitis or subarachnoid hemorrhage can affect both cerebral hemispheres and can also affect the cranial nerves as they exit the brainstem. Neck stiffness is often seen, as well as headache, because the meninges are pain-sensitive structures.